Hi, everyone. Welcome. We're just going to give people about a minute to log in, and then we'll go ahead and get started. Okay. Well, thank you so much for being here today. We are hosting this webinar on how states can protect Medicaid coverage. And I'm Ariel Kane, the Director of Medicaid Initiatives here at Families USA. As all of you know, states have largely been unable to kick people off of Medicaid over the past almost 3 years. And because of this, Medicaid rules have surged to cover almost 90 million people. But as the public health emergency comes to an end, we're anticipating it to end in early January, states will have the monumental task of redetermining everyone's eligibility for Medicaid. Today, we hope to provide different perspectives on how states can protect coverage expansions achieved during the public health emergency and get ahead of the redeterminations process. We will hear from Marshall Wilmot. Marshall is currently the Deputy Assistant Director of System Support for Arizona's Medicaid agency, Access. Healthy Arizona Plus is Arizona's integrated eligibility system that connects the Federal Data Services Hub and Medicaid State Hub. It has processed nearly 21 million Medicaid applications since 2013. We'll also be hearing from Katie McCartan Hall, who is the Director of Policy and Applied Research for Rhode Island's state-based marketplace, HealthSource Rhode Island. HealthSource is a division of Rhode Island's Department of Administration, and its mission is to increase access to high-quality, affordable health coverage as Rhode Island strives to achieve near universal health coverage. And then we have Garrett Hall, no relation to Katie, who is a policy analyst working on Medicaid policy here at Families USA. His portfolio is mostly state-based, working on Medicaid expansion, improvements to eligibility and enrollment, and redeterminations. And then finally, answering questions on behalf of Arizona will be Dareth Cox. She is the administrator for the Office of Eligibility Compliance and Oversight for Arizona's Medicaid agency. Her administration oversees quality assurance related to eligibility decisions for all Medicaid programs, and she manages state and federal audits. With that, I will go ahead and pass things over to Marshall. Marshall, do you want to kick us off?
You bet. Thank you very much for having us. If you want to go to the next slide, I want to talk a little bit about our how we identify the people in the what we call the COVID override buckets, so to speak. So it was important for us to identify people that were factually ineligible, like they have returned their renewal form. We've gone through the whole renewal process, and we believe they appear to be ineligible. So that's what you have there is eligibility failure on that chart. And then verification failure. So they just didn't even reply to our renewal. So we've got people in both of those buckets, and then a third bucket of both things. Our systems check shows that they're ineligible, and we asked them to reply, and they didn't do it. So we've got that. So we've got right now a total of about 644,000 people in that situation, where they have a potential after we do another renewal for falling off. Then I think, as everybody knows, when you try to give people data, they just want more data. So that's what these other columns are. They wanted, specific breakdowns of people that were in these buckets from medical assistance, so Medicaid, long-term care, and then kids care is Arizona State Children's Health Insurance Program. And then there's other special interests, children's rehabilitative services, homeless, veterans, children, seniors, people in federal emergency services. So we've got them all broken out like that. So it's really important for us to have identified all of these different groups in order to be prepared for unwinding when it comes. So we can go to the next slide, please. So I think one of the most important things that we've done to try to be prepared for unwinding is to align our households. So previously we've been performing renewals at an individual basis. And especially now in COVID, with the COVID overrides and everything, it's mixed up households. So, we could have people, in larger family replying many times a year for renewals. So we've gone through the process of combining everybody into combining renewals into households so that we can tell your household to renew one time instead of having to do it multiple times. Now, HEA Plus or Healthy Arizona Plus, our integrated eligibility determination system, also accepts applications for SNAP and TANF for our sister agency, the Department of Economic Security, who does most of the Medicaid eligibility determinations for the MAGI groups and for SNAP and TANF. And they do those decisions externally for SNAP and TANF. But we have aligned all those households as well. So we've gone through this big old process of getting all the families together for the medical assistance portion, and then adding in the SNAP and TANF portions to try to get everybody's renewal done at the same time. By doing that, then we had the opportunity to reduce the burden, not only on the customers, but also on the state workers. So those workers are having to process many, many renewals. So that's our plan, and we'll be implementing that just as soon as we know what the end of the public health emergency is. Maybe even as soon as January. So go ahead and go to the next slide. We made some improvements to HEA Plus as a result of the public health emergency, and including these alert sections. So we had, everything was scrolling most of the time, and so we put in more static banners. And then when a person is in here and they're up for a renewal, it's right up there on top. Like you have a medical renewal that needs attention. All they need to do is click on that button and it takes them right into the renewal process. Next slide, please. All right, so we, as part of our communication toolkit, we've been partnering with stakeholders to get this message out. We've partnered with our MCOs, and those MCOs then send notifications to the customers who are at risk of being discontinued at the end of the PHE. I'm trying to read here. We got direct assistance from those MCOs and our community partner organization. So we have a very large network of community partners made up of federally qualified health centers across the state. They are excellent partners for Medicaid, and we definitely use them to help get the message out. And basically the message that we've been sending, if you want to go to the next slide, I think we have some examples of the message that we send. Just trying to get people to come back in to and make sure that their contact information is updated, make sure that that they have a renewal, that they were getting their renewal completed, so we have a better picture of whether people are eligible or potentially ineligible. And we've done that through many different campaigns. We actually tracked so we have this kind of graph that shows the override numbers growing a little bit. And then so we've tried to identify which one of these campaigns has made a difference to the number of contacts, the number of people that we have coming in, not only to HEA Plus, but also to the call centers. So sending out a letter. We sent out text campaigns to people that have a mobile phone listed in our system. We did robocalls, and then we've also done social media outreaches, as you can see there. Lots of LinkedIn learning, lots of Twitter and Facebook from the agency's official pages. And the most effective of any of those bullets there is absolutely text campaigns. just really nothing as far as letters, didn't see a blip in the number of contacts, and robocalls was terrible experience. But text messages, that was the magic bullet there. We did get a big spike in contacts once we sent out our text campaign. So we're going to focus on those going forward. Next slide, please. That's just, there's just a list here of all the partners that we are working with to ensure that our Medicaid populations can complete their renewals efficiently and seamlessly. And I think that's my slides. I don't know if anybody has any questions. Not been looking at the chat at all.
I think we'll save questions till the end,
Okay.
but that was great. It really seems I'm looking forward to asking you some questions about how you guys are staying on top of everything. But with that, I'm going to go ahead and ask Katie to speak next from Rhode Island.
Thank you so much. So my name is Katie Hall. I am from Rhode Island state-based marketplace. So the exchange that was created under the ACA, we work very closely with our Medicaid agency in Rhode Island, especially on the program I'm about to tell you a little bit more about. We can go to the next slide. So Rhode Islanders, if you've ever met us, you know we love to talk about our home state. But I think today I want to just give you a quick bit of context for the programs we're talking about. Rhode Island has just about 1 million residents. And currently, as of September of this year, 1/3 of our residents are covered by our Medicaid and CHIP programs. It's the highest it has been. Health Source Rhode Island, or HSRI's enrollment in the state marketplace, it sits around 38,000 customers, and we handle tens of thousands of inquiries every month related to both programs. We can go to the next slide, please. This is a chart we're pretty proud of in Rhode Island. Currently, more Rhode Islanders have health insurance than ever before. In 2012, our uninsured rate in Rhode Island was around 11%. And as of this year, it has fallen below 3% for the first time to 2.9%. We recognize that as we go forward into the phase of unwinding Medicaid, that will change. I'll talk a little bit more about that later. But we also recognize that this is a combination effect. The 2.9% is not just due to system improvements or the hard work of our teams across many departments, but also due to the pause in Medicaid redeterminations that we're talking about here today. Can we go to the next slide, please? So during the COVID-19 public health emergency, enrollment has increased significantly in Rhode Island's Medicaid programs across both the Medicaid and the CHIP programs, but now a total of 353,000 Rhode Islanders are covered by both programs, as opposed to pre-pandemic where that was below 300,000. Next slide, please. So the bullets on the left-hand side, I think you're all pretty familiar with, but just a bit about our timeline. So on the right-hand side, if the public health emergency does end in mid-January, we have devised, in conjunction with our Medicaid department in Rhode Island and other social service agencies in Rhode Island, an auto enrollment program, which I'm going to explain a bit more about in the next few slides. But that process begins with the first 60-day notice on February 1st for a January end of PHE for any of our customers who have data inconsistencies, our Medicaid customers. So if their income doesn't match outside sources, that kind of thing, they have a 60-day window to make those updates. If by March 31st, they have not updated their application, or they have updated their application and they're no longer eligible for Medicaid, and they are otherwise eligible for QHP, the qualified health plan sold through the exchange, if they qualify for the auto enrollment program, they will be enrolled as of April 1st. So the program aims to eliminate any gap in coverage that those customers might otherwise experience. Typically pre-pandemic, that was a problem that we had been trying to solve for a long time. And then this process will continue throughout the duration of the unwinding period. Next slide, please. Our goals are simple and straightforward with our unwinding response. It's primarily to keep Rhode Islanders connected to coverage and minimize gaps in coverage, as well as leveraging our shared eligibility system and coordinating with our sister agencies here in state government to keep our communications aligned, to make sure that we're talking about things the same way when we talk about them publicly, as well as collaborate on projects like the auto enrollment program. And ultimately, our third goal would be to establish some lasting improvements to the transition process between Medicaid and QHP, if at all possible. Next slide, please. So this slide is more about the questions we asked ourselves as we were developing this program. I won't spend too much time here except to say that the extension of the subsidies under the American Rescue Plan for ACA plans through exchanges, if they had not been extended recently through 2025, we would not be able to do this program. It would be cost prohibitive. So that was a critical component to keeping this program affordable, as well as reducing administrative burdens. One of the things that makes this a bit easier in Rhode Island is we do have a shared eligibility system, as some other states do as well. And what that allows for automatic enrollment program, as a baseline, we already have an eligibility determination that is sent to all customers losing their Medicaid coverage, which will inform them of the financial assistance eligibility determination and other pertinent details. So what we hope to do with this program is take that one step farther and help them to stay covered and have no gap between programs. Next slide, please. So our automatic enrollment program is pretty tailored. It is limited to Rhode Islanders who are coming out of Medicaid and have a family household income below 200% FPL, which obviously fluctuates, the dollar amount fluctuates depending on household size, but if they meet those requirements, our state program will pay for 2 months of their premium in a silver medal plan, which we have selected for them through the exchange. That plan that we selected is offered by the carrier that has the largest market share in both the exchange and Medicaid, which we hope will serve to create continuity of care at a better rate than otherwise possible. Additionally, it is a cost-effective plan at that income level because there's increased subsidies available and increased cost sharing reductions, which help lower the out-of-pocket costs the consumers face in a plan. Additionally, though, if a customer, anyone leaving Medicaid and eligible for an enrollment through the marketplace at HSRI has a special enrollment period available to them, and that would allow them to call us or come in person or go onto their customer portal account and select a different plan. They have 60 days to do that. If they don't want to be enrolled in the plan that we have selected as part of this program, they can absolutely come in and select a different plan, and the state will apply the premium payment towards that plan premium instead. Additionally, auto-enrolled customers will be able to cancel their coverage. We've made some design updates to our customer portal that created a button that will allow them to, with just a simple couple of clicks, I think it's 2 clicks, to cancel coverage, because we didn't want it to be 1 click. I needed a gut check there. So we've made system improvements in order to do that. Additionally, because of our shared eligibility system, the financial assistance consent that is part of the base application across programs has allowed us to apply the advanced premium tax credit to these customers, but by providing this opt-out function, it will allow them to not have tax liability because it can be retroactive to the date of enrollment. Next slide, please. So beyond the automatic enrollment program, and I will pause here just briefly to mention that these are not the only things Rhode Island is doing to support Rhode Islanders that are going to be impacted by the renewal processes in the coming year. This is tangential to a number of other communications efforts, address updates efforts, system updates that our teams across our agencies are working very hard on as we move towards the end of the public health emergency. But within the automatic enrollment program, we found ourselves in a very unique position as a state agency where we had a bit more money than we had originally budgeted for. And so in light of that, we've expanded the original design of the program outside of automatically enrolling to create an opt-in portion of the program as well for those Rhode Islanders who are in the same situation, coming out of Medicaid, eligible for exchange coverage, but have family and household income between 200 and 250 FPL. If they come into our system, whether it's through a navigator or the customer portal or by phone, if they select a plan, our program will make payment for their first 2 months of premium. Additionally, the program will pay for 2 months of dental plan premiums if they choose and enroll in a dental plan that we offer through the exchange. The auto-enrolled population is also eligible for that dental plan premium payment. However, it will not be automatically enrolled into a dental plan. That would have to be a self-selected plan. So next slide, please. So as I've said some of these as we've gone through, we had some unique conditions in the state that allowed us to do this, our integrated eligibility system. Our state law requires, we have a mandate for health coverage at the state level in Rhode Island. There's also that overlap between our largest Medicaid carrier and our largest QHP carrier. Additionally, the extension of the APTCs support this work. And finally, the state and local fiscal recovery funds, the SFRF funds in Rhode Island, which are funded by the federal government through the American Rescue Plan, were made available to state agencies with innovative projects, and we were approved for an allocation from that fund to pay the premium payments for this program. Next slide, please. Our anticipated outcomes are exactly what you might expect. We hope that this will keep Rhode Islanders connected to coverage. I think historically, pre-pandemic, we saw a difficult transition between programs. We didn't often see a great conversion rate from Medicaid to QHP. There was often a gap in coverage. So the hope is that this will keep people covered more consistently over time. Additionally, it's tailored to our lower income families, households that might need this coverage to stay more stable overall. There's some, maybe it's a pipe dream that this might reduce call volumes as the unwinding happens. Rhode Island is a very small state, and anytime we do, federal sized program adjustments in Rhode Island, just like other states, it's a challenge to keep up on our call volume. So hopefully the automatic transition might simplify some of that need for consumer assistance directly over the phone. And hopefully long-term, this will create some lasting improvements for us too. And to that end, if we go to the next slide, we're planning now for how to evaluate this program, how to track customer experience as best we're able throughout the process. So looking to see were we successful in helping Rhode Island stay covered. And then also we have a curiosity around whether or not outcomes will differ depending on the income level, if it's an automatic enrolled or somebody who comes in and shops proactively. And so we are trying to think now what we might need to know to continue to improve on this. I think that's one of the challenges as we think through this program, the automatic enrollment program, is that it will happen every month for an extended period of time. So we want to be watching for how we can make it work consistently and better over time. And I think that's the end of my slides, and I look forward to answering some of your questions in the Q&A portion. Thanks.
Thank you, Katie. That was really interesting. And we already have a bunch of questions teed up for you in the chat. I know that we're going to lose Marshall, so I did want to just ask him one question before he hopped off. Were you able to use a peer-to-peer texting program or a broadcast texting program? Marshall, if you're still available to us. I'm here.
I just need to I guess I have a clarifying question. So by broadcast, do you mean?
I think they mean like it's a centralized text going out versus like people individually texting.
Oh, okay. The answer is that we did the broadcast, not peer-to-peer.
Okay. And were there any legal concerns that you had about texting people, or had people opted in by sharing their phone
Well,
number?
we do have when people create an account in HEA Plus, they opt into their preferred communication method. And so people opt in to text theirs, but we were, I guess our general counsel gave us the okay to send
Yeah.
these out and let people opt out, because I believe that was something that CMS had been talking about.
Awesome. Thank you. That's really, really helpful. I know I just wanted to catch you, but thank you so much for your
Thank you.
time. We really appreciate it.
You
And
bet.
now we're going to turn to Garrett, who's going to be presenting next. It's all you.
Hi, everyone. Again, I'm Garrett. I'm a policy analyst at Families USA. And today, for my part of the presentation, we're going to talk about pertinent info on the PHE and ex parte process, clear achievable goals you can champion in your states, and then go through a checklist of vital changes to increase ex parte rates. And these come from a publication we released at the end of August, which is available on our website. I think it'll also be put in the chat. And so I just want to start with this. I know Katie gave some context on the PHE timelines, but want to give some additional info. And I'm sure many of you are aware of these. But this is a graphic from our publication, and but want to show like kind of where we stand right now. So around October 15th, the PHE was extended about 2 weeks ago, as many of you probably know. And that places us in this blue bar right here. And so this is like approximately where we're at. The next big date is the possible 60-day notice that the Biden administration has promised that they would announce if the PHE was going to end. And so that could potentially come around November 12th if the PHE is going to end in January, and plus or minus a few days. And if it does end in January, then coverage losses could start on February 1st. There is a potential that we could get an additional PHE extension. That's that green bar at the bottom. But we do kind of think and sort of expect that the 60-day notice might come just in the next few weeks. And so states can start initiating but not finalizing beneficiaries renewals at that 60-day notice mark. Not all states may initiate renewals immediately. They may wait until the PHE is definitely over or a few months into the redeterminations period as they get their systems up and running. But in mid-November, some states and beneficiaries could officially be on the clock, meaning states don't have a moment to lose to start making the changes that you have already heard about today and that we'll talk about in the rest of my presentation. And the tools, as you've already heard today, that states can use to prevent coverage losses fall into outreach strategies, like some of what Marshall and Arizona have been doing, and the system-based strategies like Katie and Rhode Island touched on, and that we'll touch on today. And many national advocates and others are focusing on outreach strategies, but we're going to keep focusing on the systems-based ones, namely the ex parte renewals process. And just so we're all on the same page, ex parte renewals are required under federal law and is the process that uses data sources to assess a beneficiary's eligibility without having to contact them through like mailed notices, which can be super burdensome. And so this is crucial for limiting those burdens on both the state and the beneficiary, and just helping to, is a major tool to help preserve coverage. And last week, CMS actually released a slide deck on strategies to maximize ex parte renewals, a lot of which they included that we'll talk about today. And I wanted to spotlight this diagram that they put in their slide deck. It's much simpler than the diagram they also included on the renewal process without ex parte. And so I think the slide deck will be put in the chat, but for your reference, there's a lot of really good info in there, but it's just a good comparison between the two because this is much simpler and straightforward and efficient than the other process. And despite the legal mandate, states used ex parte renewals to varying extent before 2020, so before the pandemic and the continuous coverage requirement was put in place. Only 9 states used it for greater than 75% of their renewals. And you can see here all of the states that used it for less than 50% or less than 25%. And raising these rates will be critical to keeping people covered during redetermination, because it's just so much more efficient and it doesn't rely on people responding to mail notices, especially with how many people have moved and may not have updated their addresses. Okay, so we released in August this checklist of recommended actions you can use to push your states to increase ex parte renewals and keep beneficiaries covered. And we divided our recommendations into transparency and goal setting, high impact legislative and systems changes, and critical technical changes. And I'll just leave this up for a couple seconds for you all to process it. CMS included many of these items in their slide deck released last week. And then we'll go through each category of recommendation that we have on here. So for transparency and goal setting, the number one thing is for states to publicly release an unwinding plan. Federal guidance requires states to develop a plan and submit it to CMS. We also want it to be released publicly so that advocates, beneficiaries, and other stakeholders know what's coming. Currently, 28 states have released their plans, and that's really helpful for all those groups to be able to prepare for the new changes. We know some states are waiting until the 60-day notice is announced so they can put those timelines into their unwinding plan. But given that some states can and may start initiating renewals then, advocates like yourself should push their states to release these plans without delay. Georgetown Center for Children and Families is tracking which states have released their plans. I think that link will also be put in the chat. And secondly, we want every state to set an ex parte rate floor. So to be in better compliance with federal law, requiring states to maximize their ex parte renewals, states should strive for a floor of 50% of their renewals being done through ex parte, and then increase that to at least 60% over time. That floor will keep a lot of beneficiaries covered. And if you remember the map from a few slides ago, you can see how many states that would impact if they had a floor up to 50% just because of how many states were below 50 or even below 25. And then we want every state to transparently report ex parte data and outcomes. State advocates should push their states to publicly and continuously release this data so that they can work together in real time to inform the progress needed on ex parte rates in that floor, and also how much outreach continues to be needed as we move through the unwinding period. So 28 states have released their plan, and again, the 50 to 60% floor. And then our next category is high impact legislative and systems changes. And we want states to incorporate the full spectrum of data sources into their ex parte process. And data sources can be like SNAP and TANF, DMV data, Social Security Administration data, unemployment insurance, and the list kind of goes on. But this is our number one systems-based strategy, because with more data, there's less likelihood that states will have to contact beneficiaries for additional info to be able to process their renewal or check their eligibility. And states can pursue a temporary Section 1902 E14 waiver to deem SNAP beneficiaries eligible for Medicaid without conducting an additional redetermination. And as of earlier this month, 12 states have this authority given by CMS. There's a CMS webpage that's tracking all of the authorities that states have gotten through these temporary 1902 waivers. And so if you want to see what your state has done or find comparable states that you can use to put your officials on, that's a great place to go. I think that will be put in the chat as well. And then we want states to enact legislation to auto-enroll beneficiaries, and you heard about this from Katie, and we really view this as a model, as a policy with model language for other states if they can pass it early enough next year to implement and keep people from losing coverage. And a recent MacPac report showed why the policy is so necessary. In 2018, only 3% of people who lost Medicaid or CHIP regained coverage on the marketplace within 12 months. And so by auto-enrolling them, you would increase that percentage, hopefully a lot. And then finally, for this slide, states can pursue express lane eligibility and a facilitated enrollment state plan amendment. And these are more permanent versions of the 1902 waivers that will allow states to use eligibility and income determination from other programs like SNAP to consider Medicaid eligibility and just expedite that renewal process. And then we have a few additional high impact legislative and systems changes recommendations. The first is for states to extend ex parte to non-MAGI groups such as disabled people. States are actually required to use ex parte renewals with this group, as well as MAGI populations, of course. And CMS talked about this in the slide deck that they released last week in a bit more detail. States should alter their business rules to ensure ex parte is available for non-MAGI populations, and states can also use 1902 waiver authority if asset verification data is not returned in a reasonable time frame to just go ahead and renew these non-MAGI beneficiaries. And 15 states have been granted that authority so far. And then secondly, states should examine their data hierarchy and by revisiting their business rules to ensure all relevant data is assessed in a stepwise fashion rather than just consider the first data source that comes up. This could take time to implement, so states should begin now, but that will allow, if you're using the full spectrum of data sources, that will really allow all the information that could be pertinent to someone's case to be considered and rely less on those mailed notices for additional info. And then finally, states should fully automate the ex parte process. This is when ex parte renewals are most efficient and effective at preserving coverage because it doesn't rely on human touch and any delays or cases falling through the cracks that could happen with that. And some states have fully automated their processes already, and others like North Carolina are currently making progress. But this also takes time to implement, and so something that states should move on quickly. And then all these recommendations were included in CMS's slide deck, and so would refer you to that for additional info. And for our last category of recommendations, we have our critical technical changes. And the first is to remove requirements that beneficiaries must consent to the ex parte process. This pretty much would defeat the idea of ex parte where you don't need beneficiary contact to renew somebody. And it's also not allowed under federal law. And CMS discussed this as well in their slide deck. States should also waive consent or confirmation requirements when getting beneficiary contact info from managed care plans, and you can use Section 1902 waiver authority to do that. And 25 states have done that so far, have that authority. And second, they should maximize the time periods that data sources can be considered usable for ex parte determinations. Restricting how recent data must be limits ex parte rates. So saying we're only going to consider SNAP data if it's within the last 30 days. States should review their business rules to reflect the reality of data collection, especially given delays that might have happened during the pandemic. And CMS also included this in their slide deck with the language that says data is reliable if it was verified in the last 6 months or if it was verified more than 6 months ago, but is not that subject to change. And then finally, states should remove any limitations on the number of times someone can go through the ex parte process. Ex parte needs to be available regardless of how many times someone has been renewed through that mechanism. And they should revisit their business rules to be in compliance with federal law on this. And so just wanted to return to this slide because, again, at the 60-day notice mark, some states may choose to start initiating but not finalizing those renewals. And as you've heard, many of these changes will take time to implement or time to pass through the legislature. And so states should begin to consider them and move on them as soon as possible. And with that, I think we can turn it back over to Ariel.
Thanks, Garrett. That was great. So we have a number of questions queued up in the chat that I want to go ahead and ask all of our panelists. I'm going to start with Katie. Katie, were there any legal concerns or challenges to the auto enrollment program that you guys are doing?
There were not any challenges. No, we certainly were conscientious of I'm trying to figure out how to phrase it. One of the things that this program does is we are making a binder payment for a consumer. So their first month of coverage, the payment that you make when you enroll through the exchange, it's an agreement. It's saying that you have you agree to purchase a self-insurance plan and you're required to make a payment every month thereafter, so long as you're enrolled in the plan, right? And so that was certainly a large logistical and legal concern for our team to make that binder payment on behalf of the consumer. So there's a couple of things that we have done to help mitigate that concern. One that I discussed in my presentation is the opt-out button that we've added to the customer portal for those users that are automatically enrolled. It is, like I said, I believe it is 2 clicks. It is not 1 because we didn't want to make it that simple that someone could do it by accident. But it is as simple as we could make it to opt out of the coverage and have it be retroactive to the date of enrollment. So it would make it like the coverage was never in place. That was one element. The other is that with our shared eligibility and our shared application, when a consumer applies for coverage and they sign their application, one of the things that they do attest and agree to is accepting or being made eligible for financial assistance through the portal, whether they end up in Medicaid or on our programs through the exchange. And so that consent covers both programs. So from a consent and the legal consent standpoint, we felt we had, and we confirmed that we had the legal ground there to enroll customers automatically. In addition, we have made the communications, we have made adjustments to all legal notices that are sent to people that are automatically enrolled in this program, which was a large undertaking. If anyone on the call has ever been involved in updating legal notices, it is not easy in the best of times. So we did everything we could to make that as clear as possible, to give people options, to understand their options. So there certainly were legal concerns. We did not receive any challenges. So we've promulgated regs within state government for this, for our agency through EOHHS as well. And also, I think there's the next question to answer that just in the same answer. Our program was created through statute. So through our governor's budget in the last legislative session last year, this program was authorized by our legislature. In fact, our part of, I mentioned in my presentation, we found ourselves with a larger budget than anticipated, and that was due to our legislature extending the program's reach from 1 month of premium payment, which was our original program design, to 2 months. So they doubled the size of the program in statute when it was passed by the legislature in the governor's budget. So yeah, we certainly had, there was a lot of consideration there for the legal constraints.
Awesome. Thank you. That was a great answer, and thanks for looking ahead to the chat and answering even more questions. So I know we have Dareth on as well because Marshall had to drop, and I had a question about the Arizona presentation. It looked like you guys had really good data, and so I was wondering if you if you had expectations about where people rolling off Medicaid coverage were going to go. Like if you anticipated them getting employment-based coverage or moving to the marketplace.
So I would say, I don't know if that specific data has been looked at. However, I do know that if we show that someone is over income for our program, we do send them information about the federal marketplace. So we do provide them that information.
Got it. But you don't have information on if they have coverage through employment or not.
So we do, as a part of our eligibility, we do ask them if they have any other coverage. So we have information in that way if they've provided it to us. But no, we don't have any other information other than what they've provided.
Got it. Thank you. That's really interesting, and obviously we want everyone to transition to where they can get coverage. Garrett, someone asked, who are the main points of contact providing information on individual states' unwinding plans? Like, where can people go and look for that?
That's a great question. If you're looking for an individual state, such as like, I know Arizona has publicly released their plan, so is California. Those will be available on their state Medicaid agency's website. But Georgetown's 50-state unwinding tracker is a great place to see all of the states that have released their unwinding plans. And for the states that have not released their plans, contacts within the Medicaid agency would be the best place to go to talk with them about what their plans are to release those plans, like if they might do it at the 60-day notice timeline, if they're going to do it afterwards, or the requirement is that they release those plans to CMS. And so if they don't have plans to publicly release the plans, then that would be something that you might want to push on as a state advocate. I know I said the word plans a lot in that answer, but
that's okay. Okay, so I have two final closing questions. The first one is, as state officials, so this is for Katie and Dareth, what support would be helpful from the federal government at this moment in time?
That's a great question, and one that we have been kind of mulling over at different, I think there's different ways to answer that, but I think if from a marketplace perspective, so as a state exchange, if there was any way that the federal government could better streamline eligibility across programs, we have some challenges there where the Medicaid, for example, a quick example, the Medicaid eligibility is determined on monthly income, whereas QHP eligibility for assistance is determined on annual income. And there are seemingly small details like that, I think across different social services programs for eligibility, that if it were more aligned, it would make any transition simpler. And I think the other one that jumps to the top of my mind is a permanent extension of the subsidies. I can't adequately express how much that has changed the customer's experience interacting with our system. Rhode Island has historically had relatively low premiums compared to the national market, and it has changed many things for our customers. Our enrollment, our average premiums have dropped to often below $50 a month for many consumers. So it's something that if that were to be made permanent, the policy levers that we could implement as a state change, because we could count on, especially for families or individuals under 250% FPL, having more support through the federal subsidy program that we could leverage to streamline our programs and policies that we might pursue in the future.
Awesome, great answer. And then Dareth, what about for you? Anything specific that the federal government could do to help?
I would say for me personally, one of the things that comes to mind is I know it's under consideration with CMS. They have it out for public comment right now, and is the application for the proof of application for potential benefits. That is one of the areas that we see that we don't always receive responses from the customers when we send out. And if that was the only eligibility factor still pending, it feels like that's a little bit of a barrier. And so I would love to see that be put into play.
Got it. And then we do have, I lied, so I have one more closing question, but before that, Dareth, are there any other outreach strategies that Arizona is considering for those, harder to reach people who didn't put their cell phones in, people who maybe hadn't yet responded to emails or things like that? I know Marshall had mentioned a number of outreach efforts.
Yeah, so we really have tried to reach out to the customers in any way, anytime we have contact with them. So we do, if they've given us, an address, we've been mailing letters out to their address. There have actually been some, I would say the social media campaigns have put that out. I know that is technological, but I think it also gets people talking about it. In addition, we do have a really large assister base where we have teams of assisters who are out in the community and help with applications for our customers. And I would say a lot of people go to our assisters when, maybe they have some challenges with their technology. And so the assisters are able to apply on their behalf. So we have communicated a lot with our assisters and ask them to be communicating with the folks who come into their offices. So I would say that's one of the biggest non-technological approaches that we've had, in addition to mailing letters, obviously.
Thank you for that information. I know you guys are doing a lot on that front. So for kind of closing thoughts, Garrett, I'll turn to you first. When you think about this, huge number of impending redeterminations, what is something that sort of, this is a negative, I don't mean it to be a negative note to end on, but what sort of keeps you up at night? What are you thinking about looking forward? What do you want other people to be thinking about?
I think that the ex parte renewal process is such a crucial tool to be able to renew people without them having to reply, without necessarily having mailing addresses updated, because that is a huge problem that states are seeing with returned mail, and that raising those ex parte rates can take a while. And I think that is something that keeps me up at night, is that it can take a while to get where you need to be able to preserve the coverage for everyone who is eligible. But really crucial timing that CMS just released their slide deck last week that states can follow to improve their ex parte rates. And so that's also a resource for all the state advocates on the call. And we have the publication we released in August that mirrors a lot of what CMS says, and that you can use as well.
Awesome, thank you. So what I'm hearing is that you were ahead of CMS, so that's great. Katie, what about for you? So any sort of closing thoughts, and what are you thinking about? What do you want other people thinking about as we kind of, maybe see the end of the public health emergency?
Sure. So I will start by adding, Garrett, I was looking at your paper before the meeting today. It made me look up our projections for Rhode Island, and we expect currently to put of our 353 enrollees, 284,000 through passive renewal. And so that's something that I think it's definitely on our state's mind. But I think what's keeping me up at night, which is the exact right way to say it, that this is going to happen every month for 12 months or more. I think that none of the work we do in state government happens in isolation. There's a million other things that could impact our systems and our states and our state budgets. There's a bunch of elections happening in a very short amount of time. And I think that all of those things give me pause that as we approach this, this is not a one-time effort. This is a consistent effort to be made over time, and that will take a lot of lift. And so I think, and it can, that's where we're at, I think, or where I'm at.
That's a great point, and well received. Thank you. And Dareth, any closing thoughts on sort of what you're thinking about looking forward, and what you're thinking about in regards to the redetermination process?
So I would say to echo what Garrett and Katie said, I mean, we definitely we focus a lot on our passive renewals. Arizona does have about an 88 to 89% passive renewal rate. So that's really important to us. And I would say right now, it feels even more important because we do have an envelope shortage. And Arizona has, currently over 2.4 million members. So sending out a renewal to each one of them is on our mind. So I think Marshall talked about aligning our renewal dates for entire households, and that has been a big part of our effort. So we're feeling good about it. We've done a lot of research analysis, and we do feel good about it. But I would say the one thing that is kind of always in the back of our minds right now is the envelope shortage. So we are trying to really stay on top of that piece.
Well, that was nice to end on an optimistic note. Just add the envelope shortage to everything else that seems to be in short supply. But thank you all so much for lending your time and providing such great information. And to our audience, thank you for such smart questions. As we mentioned, we dropped some resources in the chat, but some of those are also, like Garrett's redetermination checklist is available on our website. And also I wanted to flag that registration for our Health Action Conference is now open. The event's in January. And again, just thank you. Oh, that was just dropped in the chat, so you can refer to it there. But thank you so much, and have a great rest of your afternoon.